And it's going to kind of build on the concepts that we were talking about end-tidal and adding in PaCO2 and stuff. Adding it in stuff and stuff. Okay, acid-base balance and arterial blood gassaroo. What's the point? Why do we care about this?
How acidic your blood is?
Yeah, why does it matter? What's the point in understanding acid-base balance? How does it benefit us?
Because without homeostasis, you die.
Yeah. Right? Because at the end of the day, all things have to be in moderation for homeostasis. Now specifically, we'll be using terms like acid versus base, or acidic, or to be in acidosis versus to be in an alkaline state or alkalotic state. You'll hear me say alkalytic all day long. Might be. All things in moderation, right? That includes pH for sure. Will you die if your pH is too low? Yes, you will. Will you die if your pH is too high?
Yeah.
Right? And so it's never a question of like, oh no, acid is bad. Well, too much is, right? I recommend like 1.5 tabs, that's about it. Right? But it's this way for everything, right? Sugar, fat, muscle, oxygen, all these things, right? But it even goes so far as to all of these kinds of things, right? Is pain bad? Depends, right? One of my favorite quotes of all time is, "You must all suffer the pain of one of two things, the pain of discipline or the pain of regret." Right? But you get to choose. So I always say, everybody's a slave, right? You're all slaves to something. You don't get to choose whether or not you're a slave, but you do get to choose a master, I think. Do you work for money? Do you work for yourself? Do you work for love? What do you do? Now, here's the somewhat frustrating part. You will never, ever in 1,000 million years know what arterial blood gas is in the field as AEMTs or otherwise. Because you literally have to draw arterial blood out from a patient and then test that in a machine, right? So you're just not going to know that. But they want you to understand what's happening there because it helps you understand the foundations of all of these other physiological and pathophysiological situations. Don't be like me. I asked a nurse once, because I am a tiniest of nincompoop. As she was drawing up the blood for her ABGs, I said, "Wow, I know how to find veins. How do you know where the artery is?" And she was like, "It's got a pulse." And I was like, "Yeah, right." That was super embarrassing. Because in my mind, I was thinking like, I can palpate vessels, I can see the blue lines. How the hell would you find an artery? And she's like, "How are you a paramedic?" Well, I was probably EMT at the time, but so. And it was like, how do you not know about pulses yet? So, whatever. I spit on her and ran. Here are our components. You might have noticed if you saw that link about the AEMT vital signs that this is now at the bottom, right? We need to know normal blood pressures, heart rates, temperature ranges. We also now need to be biblically familiar with pH, PaCO2, and HCO3. Or specifically, we need to understand those ranges. There are three primary goals, three primary questions when regarding arterial blood gas analysis and acid-base balance. We need to first ask ourselves, is our patient acidotic or alkalotic? That's the first question. How would I know whether my patient is acidotic or alkalotic? Blood glucose was telling me how much sugar is in their blood, and it might imply that they are acidotic. CO2 might be in the same way. It might imply that they are, but we can't know that necessarily. And here's why we can't know. These are both good answers. Here's why we can't know. Because your body is trying to maintain a balance. Okay? And if your CO2 is building up, what it will do is try to balance the CO2 with a buffer. If your sugar is too high and you're becoming acidic, it will start increasing your respirations. Do we know that already? Right? Because here's what happens. A person, and I think I said this incorrectly come Tuesday, if my sugar is too high, I will become acidotic. The body is not super good at quickly processing sugar. It is, however, really good at making you breathe faster. So a patient who is in DKA, their sugar will be really high, therefore they will be in an acidic state, but we can't just get rid of the sugar very quickly, so we'll get rid of the acid we can get rid of, which is why we have Kussmaul respirations. So we'll get into a little bit of that later. Make sure that we remember, of course, like I said, that pH, blood levels, is death on either extreme, right? Our normal pH levels are 7.35 to 7.45. This is one of the rare, signs of a patient where we just assume the same for all humans. Meaning, there is a perfect center number here, which is 7.4. That leaves us with 5 on one end, 5 on the other end. So there is technically a middle range here of 7.4. This will come in a value later, but just don't forget here that 7.4 is perfect, meaning 7.41 is imperfect. 7.39 is imperfect. Does anybody know at this point what a 7.39 or 7.41 might imply? I don't know. I don't know about it. In a certain sense, what it means is that I'm not in perfect balance. What I don't know is if this shifts based on, if I take in a breath, it shifts. I don't know. What it implies is if I'm not 7.4, exactly dead nut center, it implies that there is a problem. But because it's not outside of the normal range, my body is compensating. Okay? Now, what we're really talking about on a molecular level is the presence of hydrogen ions. Okay? It is essentially there's a lot of different ways we measure acids. One of those is the concentration of hydrogen ions. So it is essentially synonymous to say you have more hydrogen ions, therefore your pH is lower. If I have half of the hydrogen ions, if Courtney has half of the hydrogen ions in her blood as India, what do we suspect about her pH? About Courtney's pH? She has half of the hydrogen ions that India has. A large amount of, let me go to another picture, might help represent this a little better.
Or India is very alcohol. So it's low.
The more hydrogen ions that you have, the more acidic you become. It's a little like adding negative numbers. You say, well, 35 is a very high number. So, well, it is unless it's a negative number, in which case it's actually a very low number, even though it's 2 digits. So what I'm telling you is that a lot of hydrogen ions decreases pH even though we're adding something. Think of this like lemon juice, right? If I'm pouring lemon juice into your blood, I'm adding something, but the number's going down.
You're adding acid.
I'm adding acid. And you said, well, what is acid? It's just what we call hydrogen ions in a group, basically.
So what are the numbers? Why is
So the higher,
lower numbers?
Sure.
What are you measuring?
the higher you add, the lower
The more hydrogen, the lower it goes? I don't know. But my suspicion is one of 2 things. First of all, there are a lot of ways to describe acids that aren't just hydrogen ion concentration. Secondly, my assumption is even though it's easy to say hydrogen ions, my suspicion is this process started at the description of the hydroxyls, because the more hydroxyls I have, it makes more sense. in a certain sense. The more OH I have, then the higher the number goes. That makes sense. Well, the inverse of that is the hydrogen ions. The reason why I think in the medical field we emphasize the hydrogen ions is due to kidney excretion and the glomerular capsule, but we can get into that. What am I showing you a picture of here? We saw this once, at least before, or a similar version. Yeah, our red blood cells. This is the oxyhemoglobin dissociation curve. What do I care that you know about acidosis and hemoglobin dissociation? When a person becomes more acidic, the affinity for oxygen goes up or down? Down. So we know that to be in an acidic state is a problem, yeah? There's also a problem with many other situations going on, not the least of which is that if we add hydrogen ions to our blood, like to our fluid, into our vessels, those hydrogen ions will go into the red blood cells. Does anybody have any idea, I wouldn't expect this, but any idea why having positive hydrogen ions in your blood is a problem? Your body's always trying to what? Balance itself out, right? So if I'm adding positive ions, then that means whatever positive ions are in there currently have to go. And the one we're talking about is potassium. So if I pour lemon juice into your blood, which is really just a big pile of hydrogen ions, that will go into your red blood cell and push out your potassium. Your blood level of potassium will go down. Does anybody know what having too much or too little potassium might do to you? Sure. It causes this.
We had a lady who was having a stroke, but they thought that she was hypokalemic.
Hyperkalemic, hypo.
Hyper, I don't know.
Both of
But
them can do
that's-
this.
They had no idea. And it was very obviously a stroke, but they had no idea.
We talk about the lungs as mechanical and chemical, but we also talk about wait, what did I just say? Lungs or heart? Whatever. We talk about heart and lungs as mechanical and chemical. And when we get into cardiology, we're going to talk about how the mechanical aspect of the heart is the squeeze and it's moving blood, and how the chemical aspect is the electricity. And then the question will be, well, how do we get electricity in our body? To which my response would be, everything in existence outside of thought is electronic. Everything is how electrons play with each other. And it turns out when you have a cell and you swap sodium and potassium, a spark happens, let's say. And so what we need continuously is this sodium and potassium changing sides to start sparks to generate our heartbeat. If that potassium isn't there to shift back and forth, then it will cause dysrhythmias. The point I'm making to you is we now know that being in an acidic state is going to cause less affinity for O2. We know that now, yeah? Mostly what I need you to know is that being in an acidic state will lead you more likely to lethal dysrhythmias. That's mostly what I need you to know. Now these are two different lethal dysrhythmias. What would asystole look like? This little line right here, right? These are two different ventricular dysrhythmias. One of them looks more organized than the other. Is that obvious to you?
Yeah.
When differentiating VTach from VFib, we're really trying to ask ourselves the question, which is this wholly disorganized or not? Because it might be difficult in an isolated experience. If I was just looking at this, that might look like VTach, right? If all I had was this. But then I look at this one and I say, wait a second, this is different in shape. So is not that one so much, not that one so much, that one definitely, and it's even more different than this one. What's happening here is a cell is discharging and we're watching its electricity. Arguably, or perhaps, the same cell is discharging, hence why it looks so similar. This one is very different, which means a different cell in the heart is discharging. In fact, a lot of different cells are discharging. That's why they look different. If it was the same one every time, it would look like this. Because it'd be uniform. But we kind of know that, right? We kind of know that if the electricity is following one path, it'll follow that path until something changes. But if we charge it from all these different angles, right? And so that's VTAC. That's VFib. VTAC is your ventricles only beating, okay? But they're beating regularly. Can you live with VTAC? You can, right? That's why we have to check a pulse with an AED, because sometimes VTAC is sustainable, but not on a long timeline. It could be pulseless as well. But when your ventricles stop beating from the same instance and they start fibrillating, we have no organized mechanical movement at all. It's all these different impulses. And so again, we know that an acidotic state can cause a lower affinity for hemoglobin oxygen association, but we now also know that an acidic state makes us more likely to have a dysrhythmia. Which ones? Well, VFib, VTAC, or on a long enough timeline, 0. All right, second question.
That's not creepy at all. Never.
We want to ask ourselves first, is my patient acidic or alkalotic? And we do that through pH, right? Is it low or high? Secondly, we want to ask, okay, so we know it's low or high, whose fault is it? Is my patient V, the ventilation issue? Or is my patient acidic or alkalotic because of a perfusion issue? Q, that's the next question. We associate CO2, or specifically their PaCO2, now pressure in the lungs, in the blood of CO2, we associate CO2 with our ventilation, okay? If I said to you, your patient is acidic because of their CO2, is that metabolic or respiratory? Your patient has a CO2 problem. It's leading them to acidosis. Is that metabolic or respiratory? If you know that the CO2 is the problem, then it's going to be respiratory. You're not all the way wrong, though. Not all the way wrong, though. What I mean is what question you're going to be asking yourself is, okay, I see my pH is 7.2. Is that acidic or alkalotic? It's acidic. The next question is, well, is it my lungs or is it my kidneys? Is it my respiratory system or my metabolic system? Well, so naturally we just look at the CO2. The CO2 is abnormal. I'm now starting to think it's its fault. Okay, we'll keep moving. It may give you other questions. The PaCO2 in the respiratory system, or the PaCO2 is largely governed by the respiratory system, and it happens in minutes. What that means is you got test questions coming that say, which is faster? The buffer system for your lungs or the buffer system for your kidneys? It takes a long time for your body to filter things and process things and balance you metabolically. But we can do so fast with respirations. I go over there, I take a bunch of acid, I inject it into your body. You suddenly become acidic. Your body will immediately speed up the respirations to start pitching the only acid it can get rid of. You say, well, slow your respirations down, just process the acid, you'll be fine. It'll say, that'll take 4 days. But if I just get rid of the CO2, I can balance it now. Okay? And part of where this happens is you say, well, isn't DKA metabolic acidosis? The sugar is causing an acidic state? And I say, it is. And you say, so are you breathing off sugar then? I said, no. It takes days to affect the sugar. You breathe off the only acid you can control. So diabetic ketoacidosis patients actually have low end-tidal even though they're acidic because they're breathing off the only acid they can control. Or at least they're breathing off the acid they can control quickly. Your pH range is 35 to 45. This one is, you have to reverse something in your mind. Meaning, if my pH is low, I am acidic. But if my PaCO2 is high, I am acidic. Think of it like this. Coca-Cola has citric acid in it, yeah? You put a piece of meat in it, chews it up. So Coca-Cola is essentially acidic. Well, it also has CO2 in it. That's the bubbles. So if you drink Coca-Cola, your CO2 will go up. You're adding something, but it's making you more acidic. If you drink lemon juice, you're adding hydrogen ions, you will become more acidic. But just, this is where people get caught, because 7.35 or lower is acid, yet 45 or higher means acid in regards to the CO2. More CO2, more acidic. So let's start talking about these conditions. First of all, we talk about respiratory alkalosis. What type of pH should we suspect for a person who is alkalotic because of their respiratory situation? What?
Alkalotic?
How do you take acid? You drop it, right? You drop acid. So therefore, if a person is alkalotic, not acidotic, what would we anticipate about their pH?
Oh, the number's high.
The number would be high. You drop acid, bases go up.
I was thinking like the acid's low in my head, but that did not come. The words weren't correct on the outside.
Your experience here is why this is so hard, because you're gonna have to like read it like a snail.
Turn that around.
Wait, hypocapnia because of hyperventilation, respiratory alkalosis, like you have to go slowly through it. I do.
Yeah.
Hyperventilation is not always pathological. When is hyperventilation the cure, not the cause? When it's keeping you alive. When would hyperventilation be benefiting a person? DKA is a good one, right? But it goes for all kinds of different situations. If your patient is acidic, hyperventilation might be the reason he's alive, right? Panic attacks and brainstem damage, right? If you have a brainstem issue that's forcing you into tachypnea and causing excess ventilation, that's pathological, that's a problem. But we know this in theory already, right? And I can prove it. Your patient's respiratory rate is 36. Is that good or bad?
Depends.
It depends. We don't know, right? The other side is not often true. Your patient's respiratory rate is 8. Is that good or bad?
Bad.
Basically always bad, right? Because a respiratory rate of 36 is a sign of compensation or a sign of distress. A respiratory rate of 8 is a sign of decompensation or respiratory failure.
Yeah.
I want to mention this too. In the past, we would advocate that people breathe into a paper bag. Why was the thinking that breathing into a paper bag was going to help with respiratory alkalosis? Ooh, when you guys get this, you are going to impress the ever-living crap out of people.
Isn't it so they can like rebreathe in the CO2 that they do in the
Yeah.
bag?
That's right. Right, if you're exhaling too much, your CO2 goes down because too much of it's coming out of you. So you do this, now suddenly when you exhale CO2, you breathe it right back in, and they say, hey, it balances you. Okay, do not do that. The registry will very likely ask you, what should you do? And breathe in a paper bag will be the wrong answer. Does anybody know why breathing into a paper bag is the wrong answer? What do you got? Less oxygen. So they're like, hey, we are increasing CO2, and they're like, dude, we'll sort that one out. But when you force out the O2 with more CO2, that's the problem. So, again, however, I don't know what the registry would say about this, but I don't think it's a crazy idea to put somebody on a non-rebreather and pull those tabs so they're rebreathing some of that. I don't think that's crazy. Respiratory alkalosis. Ray, what do you suspect about this patient's pH?
It's a higher pH.
Well done. Well done. I know. You should have stayed EMT, dude. What's funny is you will learn this eventually. Even if it's hard and difficult and you don't feel like you got it, you will learn this eventually. How do I know this? Because everybody does. You'll get this eventually. And you will suddenly realize that almost no one out in the world does know this. And your medic partners are going to be like, what did you just say to me? We can get through this. We can do this. But like everything in AEMT class, far more than EMT class, this experience here is the tip of the iceberg to getting this. If you're not practicing it at home, you're doomed. Respiratory acidosis. Tina, your patient is in respiratory acidosis. What should you suspect about their pH?
It's low.
It's low, right? See, Tina's great at acid. Tony, why would hypoventilation lead to acidosis? How could it?
Because you're not breathing out enough CO2.
Very good. This can be caused by an airway obstruction, such as maybe somebody choking you, for fun or love, I guess. We've got an airway obstruction could be an exterior problem, hands on your throat. Give me an example of an interior airway obstruction.
Information.
Say it again.
Hot dog.
Hot dog. What do you got, Luz? Choking, sure.
Information in there from like burns.
I love it. Is asthma an airway obstruction?
Yes.
Sure enough. What's the difference? Somebody give me a difference between acute and chronic lung disease. What does that mean?
Acute is short term, chronic is usually like long term or lifelong.
Yeah? Like,
3 months.
give me
So
two
what do you
names
think,
of
chronic?
disease processes that would be one or the other.
Cystic fibrosis would be
Chronic.
chronic.
Chronic, yep. What's an acute lung disease? Say it again?
From.
Yeah, it could be. Right, and realistically, any of these things could be both,
Yeah.
right? You could have COPD. You have to be careful. Some test questions, certainly mine and probably registry, will read like, what's the problem here? And then you'll be like, oh, COPD. That guy's got a history of COPD. And it's like, no, he cut his arm. The fact that he has COPD has nothing to do with his situation today. Because COPD means you have a chronic issue, not necessarily an acute issue. But could you have COPD and then today that be the reason you're having an issue? Sure. COPD would go from chronic obstructive pulmonary disease to an acute chronic obstructive pulmonary disease experience. Right. Opioid overdose can cause respiratory acidosis. Destiny, how could opioid overdose cause respiratory acidosis?
Because you have respiratory depression, you're not breathing.
Respiratory depression. Why would respiratory depression cause acidosis?
Because you're sucking up breathing.
Yeah,
Not breathing CO2.
we're gonna do just fine. Yeah, hell yeah, good job.
That's the scientific term, by the way.
Yeah, I like it. Dude, whatever gets you there. All right, we talked about pH. We talked about PaCO2 or CO2. You'll hear these things used interchangeably, PaCO2. Now we're gonna talk about HCO3, which is bicarbonate. If CO2 is the acid, bicarbonate is the base.
Huh.
Any Stain fans out there? Stain? I'm getting old. I asked somebody today, or I was talking to one of the medic students. I said, oh, you like that band? I said, how do you feel about the Deftones? And he's like, what's that? Oh. Collecting dust, kids. All right.
There was someone on TikTok that asked if Harry Styles was in One Direction.
Huh.
They were like,
Ooh.
no.
That's crazy. The fact that some kids don't
CO2 is our
even-
respiratory system, largely governed by our lungs. If I'm having a problem with CO2, I'm probably having a problem with my lungs. HCO3 is my metabolic system. And if I'm having an issue with my HCO3, I'm probably having an issue with my metabolic system or my kidneys. The metabolic system, the buffer system here to balance everything out through the kidneys, takes much longer. It involves excretion and urination and all kinds of fluid shifting, whereas respiration is much quicker. Metabolic system takes several hours. The respiratory drive can correct things in a couple of minutes. Here's our range for HCO3. Be careful, nurses use a different range than EMS. EMS traditionally uses 21 to 28, nurses use 22 to 26.
What's NP?
What is ME per Q? It is millit equivalents. I think it's an archaic use of, we don't use it a whole lot anymore, but for some reason it's still used. Like, it's its own setup. Honestly, it won't be relevant for you in any way. You probably won't write it, and you can largely ignore it because all you care about is the number, but by definition. So this is essentially the reverse. The higher the number goes for your CO2, the more acidic you are. But the higher the number goes for your bicarb, the more alkalotic you are. How could that be?
Because it's a base.
Because it's a base. If I add an acid, my acid level goes up and I become more acidic. But if I add a base, if you will,
Then you become more alkalotic.
Yeah.
Basic.
essentially, right? I am full of HCO3. I would drink pumpkin, everything. All right. So now we talked previously about respiratory alkalosis, respiratory acidosis. Now we're going to talk about metabolic acidosis. And this can be caused by a couple of different things. Now, Courtney, what's one of the causes of respiratory acidosis? Respiratory acidosis. My patient is acidic, and it's a problem with their breathing. What do they look like?
I don't know why is it having to do this.
Oh, you got it?
I don't know.
I think you do.
Is it hypo?
Yeah.
Hypoventilatory?
Why would a person with hypoventilation cause respiratory acidosis?
Because they're not breathing out enough CO2.
You got it. So now we have a person who is in metabolic acidosis. We are not talking about the respiratory drive. Well, the reason for respiratory acidosis is too much acid in the body. Too much CO2 causing acid. Whereas metabolic acidosis means that we're having too much metabolic acid. We can get there in a couple of different ways. Certainly sugar, we've talked about that at length. But also ingestion. What could you ingest that would cause you to be acidic?
Lemon juice.
Sure, let's say lemon juice. I don't know if that's true, but probably true.
You'd be surprised even.
Aspirin will do it. Why will aspirin cause you to go into metabolic acidosis? Acetylsalicylic.
Acid.
It is an acid. Ingestion of acid, lemon juice or otherwise, acetylsalicylic acid. What we shouldn't say is, oh, he just OD'd on aspirin. No one ever dies from that. Okay. Well, it could cause acidosis. Why would a person, Tony, I got a person who took a whole bottle of aspirin to kill themselves. He's got no complaints of trouble breathing. He's got no complaints of pain, but we know that he's in metabolic acidosis. What do you say to him to convince him, no, I know you're not in pain, I know you're not having trouble breathing, but having too much aspirin can kill you? How?
Because your blood, because aspirin is an antiplatelet, so your blood's not clotting as well, which could lead to
Fair enough.
buildup of acid.
Yeah, that could be it is an antiplatelet and that could lead to bleeding, that's true, but how specifically as far as acidosis, right? I'm your partner, the patient says, hey, I took too much acetate because I wanted to kill myself, but I don't want to go to the hospital because I'm not having any trouble breathing, I'm not having any pain. And my response is, well, you might still be in metabolic acidosis. And he looks at you and says, can you get this nerd out of here? What is he talking about?
Chronic cardiac death.
This wouldn't be a trauma patient, so therefore not largely relevant. Okay. What I'm asking you in a convoluted way is why would acidosis kill anybody?
I got nothing.
Too much of anything can kill anyone.
Too much of anything can kill anybody, but we know two specific things that acidosis can lead to. What do you got in here?
Lowers the affinity for oxygen.
Lowers the affinity for oxygen. What else?
It brings in the hydrogen and that pulls out the potassium from the
And can
thyroid
cause?
and BTEC or BFID.
Right? And so Tony's response would be, I'm so sorry. He is just so impressed with
You're right,
himself.
he is a nerd, let me tell you.
Yeah, metabolic acidosis, it's some chicks go for that, so like whatever. But anyway, the point is you say, okay, metabolic acidosis, I don't know what that is. And you just say, look, here's the point. Too much aspirin means that eventually you won't be able to breathe. Too much acid means your hemoglobin won't take oxygen on. Too much acid means your heart might go into a dysrhythmia because of how it affects the potassium. I know you feel okay right now, but in a metabolic acidosis state, it might be a problem. Very good.
So you could say like, well, in 4 days, it probably won't.
Yeah, sure. I would say, no sooner than we leave will you start noticing all these problems. And I say, look, there's no world here where you don't end up at the hospital, brother. Let's just do it now. In about 30 minutes, you're gonna feel much worse and a lesser man is gonna come. He's not gonna be funny. He's not gonna care about you. It's gonna suck. So let's go now. I'll tell you about my kids. You can feign interest. We'll go to the hospital. It'll be all right. I'll point out the pretty nurses. You see what I'm saying? Like, it's salesmanship, right? And he's like, all right, this guy doesn't seem so bad. Most people who you interact with in these psychological or behavioral disturbances have interacted with more medical professionals than you have, unless you also have behavioral and psychological deficits. They know the game. And if they realize you're a homie, they'll listen to you. Right? I tell people, I say, you've been in this path before? Yeah. You know the long list of shitlords that you have to deal with when this happens? Have I struck you as one of them? Let's just do this. Right? lactic acidosis, that can occur, right? Different issues like rhabdo, laying on muscles, all kinds of different things. I won't get into it too much here, but anything that leads to acidosis could cause you an issue. Is it possible that water could cause acidosis? I have no idea. I don't remember why I put that picture there.
Maybe.
I know that saline can shift it negatively, right? Why does saline shift it negatively?
Because it has a pH of 5.5, so it's acidic.
We have to then assume, or at least I assume, that it has more hydrogen ions than your blood does, because hydrogen ions lead to the acidosis. What about dextrose? Dextrose is even more acidic. What's the pH for normal saline? 5.5. Anybody know what the pH for dextrose D50 is? I don't know. 4.4. Let's say 4.4.
Yeah, we're so small.
Thank you.
That's about right.
Whatever it is, it's certainly lower, which is something we need to consider. Does that mean that I'm saying, whoa, their blood sugar is 30? I'm on a truck, you're on a clinical. Their blood sugar is 30, and you're like, wait, I suspect metabolic acidosis. Don't give them that sugar. You can't check ABGs on a truck. You have to treat what you know. Right? But it is part of the reason why we titrate the sugar until it gets to the level we want, and then we stop. It's part of the reason why we treat with fluid until we get to the level we want, and then stop. Because too much of anything can be a problem. Not class, that's only good. Metabolic acidosis on the other side could be not that you have too much acid, but rather that you don't have enough of the buffer. Severe diarrhea will take bicarb with it. You poop HC3O, HCO3. What that means is patients who have too much leaving their body could have an issue with acidosis. But it's not because they have too much acid, it's because they don't have the bicarb they need. What I need you to think of more than anything is as a woman says, I'm feeling weak today, and you say, all right, well, have you been eating? Yeah, I haven't eaten. You diabetic? No, I'm not diabetic. How about your stool? Would you call it normal? Well, I have been pooping quite a bit. Really, is it like a liquid or is it salt? How would you describe it? Just diarrhea for like 2 days. Oh, well, you should go to the hospital. I don't want to. I just felt a little weak. I just wanted to. Sweetie, you might be weak because you're in an acidotic state. Tony, why would I want, what could I tell her? Hey, you've been pooping too much. She said, but I've been drinking lots of water. I don't think I'm dehydrated. I said, well, water aside, an acidotic state could still kill you. How?
Probably have too much acid in your renal calculus.
Well, renal calculi would be a kidney stone, so that's a separate thing. What I'm asking you here is if I lose too much bicarb, it makes me acidic. Why would acidic kill anybody?
Because too much of anything can be bad for your body.
Sure, but we can be more specific. 2 things. Oxygen affinity is a big one. The second is,
Too much hydrogen, and then it causes dysrhythmias in your blood because it takes out potassium.
great. So I'm going to say this to you, and then you say it back. An acidic state can kill you
Acidic state can kill you
because it lowers the affinity for oxygen,
because it lowers the affinity for oxygen
and it can cause lethal dysrhythmias.
and can cause lethal dysrhythmias.
Your patient is pooping themselves to death. They say, I don't want to go, get out of here. You say, you might be in acidosis if you're pooping too much. And they say, why is acidosis a problem for me? And you say,
Because it can cause dysrhythmias.
good enough. We can also have a problem with our kidneys, much like you were kind of in the area of, which is simply not that we don't have too little bicarb, not that we have necessarily too much acid, but rather that we're not getting the acid out that we need. This will come into discussion later during our cardiovascular discussion, but when we have aldosterone and it's not letting sodium be released, then it's not letting hydrogen exchange. Now, I don't need you necessarily to remember this right now, except for to say there are a lot of different reasons, a lot of different ways to skin a cat here. What I'm trying to avoid is you saying, it's just a little bit of fluid coming out, and if it's a little bit of fluid, then it's no big deal. That's not the case. All kinds of molecular shifting happening. So we talked about acidosis, now we're talking about metabolic alkalosis. Amanda, we know your patient is in metabolic alkalosis. What should you suspect their pH is? Sure.
It should.
Your homework is to do LSD. How do you take acid? You,
For real?
I guess.
I'm confused for your question.
You drop acid.
Drop acid. Okay, so it'd be the low the most? The
Acidic, dropping acid, lower.
Lower.
Your
So-
patient is alkalotic.
So it'd be higher.
There you go.
Okay.
Don't do illegal substances. Okay.
Can't help us anything.
If
My teacher told me to.
you can't prove it. Loss of, you can lose hydrogen ions in a whole bunch of different ways, and one of the most common ways is through vomiting. Now we lose bicarb through our butt, but we lose hydrogen through our vomit. Does anybody know why? Because your stomach acid.
Yeah.
Your stomach acid, hydrochloric acid, has hydrogen ions. If I'm puking out an acid, my overall acidity decreases. Can I say that? If I get acid out of my body, I become more alkalotic. Somebody throwing up might have less acid. Or you could have too much bicarb. So either not enough acid or too much bicarb. But this is just the balance we're talking about. Why would a person have a high pH? Well, because they took a bunch of high pH stuff, or they got rid of a bunch of acid. Either way, it will level it one way or the other, or angle it one way or the other. Somebody says, oh, I just took a bunch of Tums. I said, well, how much is a bunch? Because this bottle's empty. He's like, well, I did take the whole thing. How do you feel? Fine. Pulse ox is good, blood pressure's good, heart rate is good, all these things are good.
But you might not use it.
Well, let's just do a refusal. Wait a second, right? Your metabolic system might shift. And what do we learn about metabolic and respiratory shifting? One of those takes a minute. One of them takes a couple hours, if not a day or so. So this guy, much like Lucy mentioned earlier, he might not have a problem today, but tomorrow he may, right? Also to make poop weird, and that's not fun for anybody. All right, I'm gonna say this quick point here, and we'll take a break and we'll start doing some stuff. What's important to know is that what we shouldn't say is like, oh, I see, his 7 dropped to his 6. That's not so far. This is exponential. This is a short way of writing this. This is a logarithmic function. What that means is that each one of these is 10 times the value of the previous one. The only reason I bring this up is to say we shouldn't be like, oh, it's just from 7 to 6. No, that's to the tune of 10 times the normal acid level of your blood. If it were a 4, you would probably melt into a puddle. All right, let's take a quick break.
Stick around.